In this section, we will go over the remainder of the axial skeleton, or part 4. We'll finish up with discussion on cervical and thoracic regions. And just to get us started, just a few fun facts. The neck moves on average 600 times an hour, even when we're sleeping. That's really remarkable that we don't have more wear and tear in our neck region, and that we're seeing even centenarians aging well and still very active. And so it just shows that healthy lifestyle can really impact our joints and our tissues and our function. According to the National Institute of Health, up to 86% of the population will experience neck pain in their lifetime, and the yearly incidence is about 30%. If you think about that, even the yearly incident at 30%, they're only marking people that are going into the emergency room or seeking out a primary care physician. So that number is probably much higher. And if you think about even yourself and your collective small sample of who you know, how many people have had neck pain in their life. In a study in the JOSPT journal, found that 17 years after a whiplash injury, people will still contribute their neck pain to that specific time period. My mom's a great example. I grew up water skiing, and she, to this day, she's in her 60s now, but in this day will contribute her neck pain and dysfunction to a water skiing accident that she had in her 20s. So it's just really remarkable what people will remember, and it's really neat, some of the research coming out now showing that actually our fascia has memory, and we'll carry that memory forward. Really liked this quote from your Levangie text. The complexity of a structure that must fulfill many functions is reflected in the design of its component parts. Just coming back to, let's take a look at how the structure is built, what it attaches into, what its components are, if it's a dense piece of connective tissue, if it's an elastic piece, if it's bony congruences that are helping prevent motion, angles of inclination. So just really amazing design that we have, and so let's dive in a little bit deeper. Let's talk about the cranial vertebral region. So talking about, what are we talking about? The occipital, the condyles of C1 and C2, really looking at how the head sits on the neck. It's really there to cradle the occiput. We need to make sure that we have a pivot point around in which we can move. The forces are transmitted through the head down into the occiput, through the atlantoaxial region, and then down into the lower cervical spine. It's there to provide motion into axial rotation. If you think about just safety-wise, us being able to look behind us and look around us is very important in our functioning and in our health and our wellness. It's also interesting that atlas has more free space to accommodate the spinal cord, and so there's a lot of ligament stability, joint capsule stability around the area, but a lot of room for rotation to occur, and so not to compress onto the spinal cord. Motions that we'll talk about, we'll dive in much deeper into capital flexion and extension. That just means flexion and extension at C1, C2. Rotation, we'll touch on lateral flexion as well with that. So let's just take a look at that atlas. It's C1, is ring-shaped. There's no spinous process or body to it. And just taking a look and understanding that we have our inferior zygopophyseal facets right here, and then we have into this archway. This is where the dens will articulate, and we'll talk about some of the ligamentous structures that will help maintain that. And then we have our superior zygopophyseal facets as well. So just a great setup. It's often referred to as a washer type of scenario. And if any of us are non-mechanical or mechanical, that just helps to create some mobility. And then let's look at our atlas, or our axis, This is C2, has the dens. This is that nice big pointy area right here. Oops. So we just taking a look at that. Someday Mitch is going to really give me a great lesson on how to use this pen. So the dens, and if we just remember when we looked at our atlas, that the dens is going to approximate with that. So to provide more congruency into that area. And then we have our superior zygopophyseal facet joints. So we're going to understand that there's contact that happens throughout these facet joints as well, sitting onto there. Articulation. So let's just jump in a little bit deeper. So we have our atlanto-occipital, which is our atlas sitting in relationship to our occipital condyles. It's a condyloid joint, and it's primarily going to handle flexion and extension, meaning that it's just going to be a small head nod. So if you guys all sit up very, very tall, very straight, and you make sure that you aren't sitting in a forward head posture, that you actually have your alignment of your acromion process with your ears, with your hip bones, and then if you just slowly nod your head, if you put your hands at the base of your occiput and then right into there, so I have my first and my second fingers, or my index and my middle fingers, kind of contacting just the base of my occiput, and then if you just slowly shake your head, you'll feel some of that motion into that area. If you want to keep yourself there, the closed pack position is full extension. So you're closing down for that atlanio-axial. The atlanio-occiput is full extension. The atlanio-axial is made up of 3 synovial joints. It's that median atlanio-axial articulation, so we'll see that into this area right in here. And then we have 2 articulations, or plain synovial joints, and those are where the facets come into play. So we can see in here that this inferior facet contacts the superior facet. That acts like a plain synovial joint. Our articulation, let's just jump back to this median atlanio-axial articulation, is a trochoid joint, and it's really a cool setup because it rotates in this osteoligamentous ring, and that's formed by the anterior arch of the atlas and then the big transverse ligament. And that transverse ligament is like a cruciate ligament, and we'll jump into that in just a little bit more as we move on. So ligaments, this is, I just want you guys to make sure that you just kind of carry on forward what we were talking about as far as in the lower spine. We talked about the ligamentum flavum, and just understanding that that will turn into, as it moves into the spine, it'll turn into the posterior atlanto-occipital and the atlanto-axial membranes. This is really, it has a more plastic nature to it, so it's not quite as elastic, and it's there to permit an increased range in rotation. Our ALL ligament will turn into the anterior portion of the AO and AL membranes, and then the ligamentum nuchae, the PLL will turn into that tectorial membrane, which helps give some support to our atlanto-axial joints, and then the tectorial, or the ligamentum nuchae, is just from our research is just kind of undecided at this point. So we'll just kind of understand that it's very variable, and we're just not going to pin our hat really on anything at this point. So let's talk about 2 really, really significant ligaments in this area. And so we want to touch on to the transverse ligament. And that transverse ligament, really important in the stability of C1 and C2, can become really degraded in some signs of pathological disease or disorder. So rheumatoid arthritis is one of those. That's why we ask when we are clearing if we're okay to mobilize someone, is we ask about rheumatoid arthritis, because if this ligament becomes compromised or not as strong, then we actually are at much higher risk of anterior displacement of C1 on C2. And so we can see that there's really strong fibers from the dens, right? So it holds that dens in close approximation with that anterior ring. It's kind of hard to see that, but the anterior ring is this way, right? So anterior ring of the atlas, and it serves as an anarticular surface, so it's an extra surface there. It's critical in stability, and what's so crazy is that the dens will actually fracture before the ligament will tear. This is really important in cases such as whiplash, and so anytime we're evaluating someone that's been through a car accident or who we are just concerned about maybe the integrity of their tissues, we will want to check the integrity of the transverse ligament. The alar ligament is the two ligaments that support. We can see these guys right here. These are the alar ligaments. So I kind of got messy in here, and I need Mitch to just show me how to erase things, but these are the alar ligaments. I guess we can change colors really quick. That would be an easy fix. So I don't know what cyan is, but let's find out. So these are the alar ligaments right here, and they go from the dens to the occipital condyles. And what we want to know about them is as we move into flexion, they become taut, and that they're nice and relaxed in extension. They are there to, and we can understand that as we go into lateral flexion, axial rotation, that they are there to help limit that motion. So I just want you to think about and pause. What happens with someone who's in a forward head posture where they have rounded shoulders, but really their chin has moved very far forward of their body, and we're in maybe a little bit more extension through our mid-cervical spine, but we start to see in that upper cervical spine, we're kind of diving forward. And so we're probably changing the integrity of those ligaments and how they're functioning. Let's just review a little bit that the facets lie primarily in the horizontal plane, and that our OA joint is mostly responsible for that small capital flexion, so capital flexion and extension. And our AA joint is really responsible for rotation and responsible for a lot of our rotation in our cervical spine. So capital flexion and extension, and you guys will learn how to manual muscle test capital flexion and extension. This has become a key area of treatment for a lot of our patients that come in with neck pain and dysfunction, with headaches, with TMJ, is really understanding that we might do some manipulation in that area or some mobilization with movement. It's in the literature that there's about 10 to 30 degrees of combined movement. So if we go flexion to extension, so we have about 10 degrees all the way to 30 degrees of flexion. So we'll say 10 degrees of extension and then 30 degrees of flexion. I'm sorry, I won't try to draw many words onto here. It's not as effective. Our AO joint is two concave superior facets, and those are articulating with two convex condyles, and those lie in that horizontal plane. The flexion of those occipital condyles is, you'll see a roll forward and a slide backwards, and I love the visuals of the arrows so we can kind of see what's happening as we go through flexion and extension. And so we'll start to see that with flexion, we see that the occipitals will roll forward and slide backwards. So I like the arrows telling us there, and then when we go into extension, it's the opposite, that we're going to see that as we move forward. This is a much smaller view of actually what's happening, and we can see that the convexity of the occipital condyles and the concavity of the atlas on there moving through that. Rotation and lateral flexion are really actually pretty slight in this area, although there is some movement. There's no really definitive range that occurs there, just something for us to know as clinicians that we might see that. And that what is going to limit that is the tension of the capsule on the contralateral side of the rotation or the lateral flexion, which we understand based on just the anatomical position of that. So the AA is a little bit different. It's really responsible for a significant amount of rotation. It's about 55% of total rotation occurring here. Side to side, we can see a total arc of movement of about 90 degrees. The joint is, like we said before, it's a trochoid joint where the dens articulates, and then the plane synovial joints on the side where the superior and inferior facets contact each other. The closed back position is flexion, so if we go into full flexion, we'll be closing down onto that, onto that movement. What we see in upper cervical lateral flexion will couple with contralateral rotation, and then vice versa, meaning that if we have rotation, we'll see contralateral flexion with that. Let's just move on now into the rest of the cervical spine. So C2 through C6. C7 is a transitional vertebrae, and it starts to mimic and look a little bit more like the thoracic spine. C2 through C6 are plane synovial facets, and they have motion in all planes. We'll see side bending and rotation to the same side. Most often, we'll talk about Fryette's law in relationship to this. And if you guys just side bend right now, I want you to side bend to the right and just see, are you getting a little bit of rotation to the right? Are you following that rule if you go to the other side? Do you have any pain or dysfunction in your body to limit that? And if you do, are we starting to see some opposite? Fryette's law really does apply really well just because of the orientation of the facet joints in the cervical spine. So it will help us when we move into a mobilization with movement, where we might just want to consider, if I'm trying to increase rotation, maybe I can do some type of mobilization or mobilization with movement into side bend and know that I'm going to also help rotation. The foramen of the transverse process is there for the vertebral artery. That starts at C6 and goes all the way up. So regional differences is those cervical bodies are small, much smaller than the rest of our vertebral column, and that it has a bifid spinous process. And so we just want to understand it's got kind of 2 points coming out. And that it also is unique in that it has those uncovertebral joints, or those joints of the von Luschka. These joints are between the unicate superior process and the inferior semilunar facet. And they're there to help limit lateral flexion. And it's a great design because we have so much mobility into our lateral spine that we do need some of these bony checks to help prevent increased motion. So on here we can just take a look and see these uncinate processes right here. We can see that we have our foramen in here. Okay, so checking, and then just appreciate that this vertebral foramen, how it's shaped, and really allows that spinal cord to come out, and a lot of motion to allow a lot of rotation. This is that bifid process, spinous process right in here. And really like for you guys just to appreciate how long this spinous process is, and we'll start to feel that when we do our joint mobilizations, is that it's a very prominent, and it's usually in a very healthy spine pretty easy to find. Sometimes when we get into that forward head posture, we see our mid-cervical spine has that increased lordosis, and those spinous processes can become harder to find. Our facet orientation is about 45 degrees. That superior facet of the inferior vertebrae, so right in here, is superior and faces medial, and then the inferior facet of the superior vertebrae faces inferior and lateral, so they fit nicely with one another. Let's just review. This is cervical flexion, and it's the same as we talked about with lumbar and thoracic region, that we are tilting and gliding anterior. And this is just a really great picture to appreciate how much gapping occurs with flexion in between those spinous processes. So if you're having trouble trying to mobilize someone, if you just put them into a little bit more slight neck flexion, those spinous processes are going to gap for you, and now you can come in and apply your mobilization and hopefully help improve momentum or movement that way. We see that there's about a 45 to 50 degree arc through our flexion, and understanding that some people are going to only get flexion from that lower cervical spine or even that mid-cervical spine because they have just gotten so restricted in that upper cervical spine. So we want to just make sure that everything is sliding and gliding like it should. So each of those facet joints should slide and glide on one another independently. So we want to see segmental mobility throughout that. In extension, we see almost the opposite, that posterior tilting and gliding, and we see that this picture is really great because we see how much closer those spinous processes come together, and we see in this picture that the closing down of those facet joints as they're coming into that. This person has a lot of extension, and I mean that would be nice for everyone to have that much extension. You'll see with aging that this starts to decrease significantly. People quit looking up, they quit training into that area. We see that nice anterior longitudinal ligament here is really helping to prevent that motion. But if you think about if it's just becoming shorter and tighter, that now if we need to go into extension, that might be compromised. Protraction and retraction. Okay, so everyone, you're going to sit up at your desk, and I want you just to let your body sink in and let your chin jut forward. Okay, good. So now sit up again. Now put your hands high up onto C1, C2, and I want you again let your chin jut forward. You should feel significant closing down of that area. Now if you sit up nice and tall, get into some thoracic, at least neutral, probably not extension, but neutral. Get your ears in line with your shoulders. Now you should feel nice opening and gapping occurring at that area. Remember, we should have a little bit of lordotic curve in our cervical spine, and that if we start to lose that, we start to change the way in which our sternocleidomastoid works, ways in which those connective tissues are all functioning, and the ways in which our muscles function. So now we're entering into some hypertonicity of a lot of our musculature, but then also this long and weak type of musculature. Okay, let's talk about cervical rotation. The shapes of the facets and the interbody joints really do dictate motion in that lower cervical spine. So we're going to consider lower cervical spine is C5, C6, C7. Okay, so right around here, mid-cervical spine is usually C3, C4. Okay, so in that lower cervical spine, the facet joints are really there to help guide that motion. Lateral flexion and rotation are coupled together, and in this position, we can often see that lateral flexion occurs with ipsilateral rotation and vice versa. So again, when we say vice versa, meaning that if you have rotation, you're going to get some of that side flexion to occur. What's interesting is they're showing that just as we age in general, that these patterns will start to change, and those uncovertebral joints will start to change as well, and we can see some degradation at that, and that will start to affect our mobility. We talked about the intervertebral disc, and as that starts to degrade, that starts to affect our ability to move as well. So lateral flexion, just another picture for you guys to see that as we move into lateral flexion, you want to think about what's happening at those facet joints on the contralateral side. A lot of times we'll say, oh, we're opening of the facet joints on the contralateral side. We're closing down the facet joints on the ipsilateral side. This, again, is important when we look at mobility and joint mobilizations and just wanting to understand that. Okay, let's just jump into thoracic spine. Just a few more slides to go. Really looking at those long spinous processes are there, and they're there to limit extension. And they definitely do. So if you guys try to get into as much thoracic extension as possible, most of us are pretty tight nowadays, but our extension is very limited. We also have limitations because we have basically our ribs are forming a closed kind of scenario for us, or a closed ring. And so our facets for our rib joints also gain a lot of stability for that thoracic spine. Dr. Kruchowski will dive a lot into the ribs and how they function in relationship to the thoracic spine and those spinous processes in your next lecture. So stay tuned a little bit more for that. So facet joint orientation, we now are moving into a much steeper orientation, so about 60 degrees orientation. And we can just understand that the superior facets of the inferior vertebrae face superior and lateral. So it's always nice to do that with your hands. So superior and lateral. And then the inferior facets of the superior vertebrae face anterior and medial, and they fit pretty tightly into that area. A lot of people will do a lot of manipulations in this area to help improve thoracic extension because we know that that's so imperative in our ability to elevate our arm up overhead and maintain that scapulothoracic rhythm. The thoracic spine that goes through all of the rotation, all of the motions, so rotation, flexion, extension, side bending. But really where we're going to break it down is that upper thoracic spine, meaning T1 to T6. Flexion and extension is pretty limited. And so if you guys just try to isolate that out and just really take a look at what can you do just in that upper thoracic spine. And it's not very much. So if you can go through just a little bit of flexion and extension, you're going to be pretty limited due to the rigidity of the rib cage and also how much those facet joints are orientated into the frontal plane. Okay, so now let's try lateral flexion. So if we just side bend to the side, remember this is a combination movement of your lumbar spine, even your cervical spine. So everything is really moving together. But if we can just go lateral, what are we getting from right versus left? And are you feeling yourself shift? Are you going a little bit rotation same side, or are you going rotation opposite side? Take a look at yourself, see what you're doing. Maybe check out your roommate or your husband or your wife or someone else and just take a look at them. Often what we'll see though is in that upper thoracic spine is that lateral flexion and rotation are coupled and that they'll move in the same direction. That tends to change as we move into the lower cervical or lower thoracic spine, where lateral flexion and rotation will actually be opposite. And so it's just important to really look at that individual and hone in, really isolate out the structures first and then take a step back and look globally at what's happening with them. As we move into those lower thoracic regions, we have increased ability to go through flexion and extension and see some of that spinous process orientation change. So our PLL, our ligamentum flavum, our interspinous ligaments, and our capsule are all there to really limit our forward flexion, right? So understanding that those are all there to help in relationship to stopping some of that movement. Don't forget, we also have our muscular abilities. We'll have some eccentric descending control of that. Our spinous process contact, our laminae, our ALL, our facets, and our muscles, especially our abdominal muscles, will all limit extension, and we want to train eccentric control of our abdominal muscles, especially to help with that eccentric. We also want to make sure that we have enough length in our abdominals so that we can get into thoracic extension and maintain that. Our lateral flexion is typically limited by the facets on the concave side. So if we think about closing down on that side and the rib cage. And then our rotation is limited by really rotation of that rib cage. So we're kind of running into that rib cage. So just to go over it one more time. So our PLL, all of those guys in that first line, they're going to help with limiting forward flexion of the thoracic spine. The second one, the ALL and all its friends, are there to limit extension, and we want to make sure that we're focusing on what's our length of our front body wall, and what's the eccentric control of that front body wall. And then lateral flexion limited by those facets in the rib cage, and then rotation limited by the rib cage. These are pictures for you guys. This is just, again, it's following the same rules as we've seen in the cervical spine and in the lumbar spine, but just a great way to picture what's happening as we go through a functional mobility, that we see a lot this arc of mobility, and that we want that lumbar spine and the thoracic spine to each segment for it to slide and glide on each facet joint. And that if we start to get restriction, either we get unilateral restriction, so maybe restriction on the right side, that we can start to see maybe some more pull into rotation, or we get some more side bend into that area. And so this is just areas where we would want to focus. Same thing if we look at thoracolumbar extension, just remembering that it's a posterior tilt and posterior slide. It's a combination of the lumbar spine and the thoracic spine to achieve that nice big arc of motion. So we see that we achieve that nice big 40 degrees arc of motion. Just quick reminder of that ALL really limiting that extension. So nice picture there as well. Our thoracolumbar axial rotation of the lower thoracic spine tends to follow the lumbar spine, especially as we transition into that lower thoracic region. So that TL junction, so T11, T12, and then upper is moving more in with rotation and side bend into that same side. Okay. And then just lateral flexion again, just another picture for you guys to see that combination movement between the lumbar spine. So how much are we gaining in that lumbar spine to get into lateral flexion, and how much are we gaining into that thoracic spine? So if someone comes in and is complaining of pain up in here, still very important to see as they're laterally flexing what's happening up into that upper thoracic spine. T7 is going to be one of those areas of tension. So it's a tension point into our body. It's one of those areas where we'll want to examine and to make sure that they have mobility in that mid-thoracic spine, so that their lumbar spine is not taking too much of the brunt of mobility. So looking at that mid-thoracic lateral flexion and rotation is going to be important for that. Okay, guys, you did a great job. And what's next? Well, this is what tends to happen at home when I may be working on a lecture is my son gets into some of my daughter's makeup and decides to paint his whole body. So I'm sure this is how you guys sometimes feel after listening to long lectures, but you guys are doing a great job and just really love all the detail that you guys are diving into. So just keep jumping into that Lavangi text, watching videos, talking with your friends and the GA, and just keep on coming with that inquisitive mind that you guys have. Great job. Hope you guys have a great evening or afternoon, and we'll see you in class.